Assalamu alaikum warahmatullah. I just wanted to present this because I had a experience. I went there to Abu Dhabi about attending their master class. They are one of the many avenues or group of people that have come around and have made this their passion, and they want to kind of extrapolate that to all avenues of medicine, including ICU care, including nephrology care, including emergency room care. And I want to actually induce or infuse a little passion in yours as well, because you are all young blood, and this is a new technology which is cost effective, which is cheap, and it has a very steep learning curve. Once you do a few of these, of course you need an ultrasound to do this, but in our hospital there is availability of ultrasound, in the HDU, in the ICU. You can request a radiologist to actually teach you as well, how to make images, and this will actually help you a long way, because this is something that is going to be kind of standard of care in the future. Okay? And when we trained in nephrology, I was a trainee in 2011, 12 and 13. We did not learn this. We were depending on conventional ultrasounds. We would write orders, get an ultrasound done, do a bladder scan and all that. Whatever we used to do, our technologist would come in and he would do a bladder scan, and he would send the pictures to the radiologist who would read them. The technologist or the radiologist are unaware of actual patient presentation. They have to look back into looking at the clinical scenario and then interpret it sometimes, because there are too many hands off. And because there are some findings, again, I'm not saying that point of care ultrasound is going to replace conventional ultrasound in any way or form, okay? But I do understand, and I'm trying to make you understand or make you get that through your head, that this is something that can be easily learned, and there are some findings that can be easily picked up, and once you do it, you'll get better at it. There is an operator dependency. The better you make images, the better you're able to interpret them, do dimensional studies, measure whatever you want to measure. And then you can also, because you probably, the physician itself, are the best person, because they're actually seeing the patient, they are taking history, doing clinical examination. Point of care ultrasound, if you do it yourself or your team does it, that will also help it. When I went to Abu Dhabi and the instructors were teaching us, and they are master instructors and doing this for almost 8-10 years, they were saying that they have their handheld ultrasound in their pockets or on a portable machine, and whenever during rounds, if they have an issue, they would just get their probe out, attach it to an iPad or even iPhone. They have iPhone as well applications. They would just do it within, it takes like 2 minutes, 5 minutes. They would just do it, get the answer there and then, instead of having delays, okay, send this patient to ultrasound, get a bladder scan done, and it will take half a day to get that done, and then you make decisions. So it's point of care. It actually improves patient contact, improves your ability to make inferences from this, and then to implement those changes. So this is what the whole point of doing this presentation, and to get this something through, that is something that you're going to have to face. And if you do not learn this, your contemporaries who are getting trained somewhere else, they will be ahead of your game, So you have to kind of get this into. I have no disclosures. So I actually attended this Abu Dhabi workshop. This was a master class. I did not get the master certificate yet, but we had this is Dr. Hatim Suleimani. He was a personal friend. This is Dr. Siddiq Anwar. He is also a person. We actually trained together at Washington University in St. Louis. Dr. Hatim Suleimani is based in UK. He's an Egyptian, but he's been traveling all over the world. He's actually written a book as well, Point of Care Ultrasound and Implications, that is going to be published in a month or so. This is Dr. Francisco. He is actually the head of the POCUS Academy at this point. I think he's Italian. And this is Dr. Giovanni, and I forgot her name. जी So but the good thing about, and we actually did this through this Sonoflex. They had the company name Econexus, and their device name is Cosmos. It is an expensive device, but it has an artificial intelligence in it as well. It actually gives you the measurements, gives you how to make images, also helps you where to put the probe. So it has a lot of features. It has color Doppler, pulse Doppler, tissue Doppler available as well. Some of the machines out there are very high end. So this is a high end machine. But despite all its limitation, so is the stethoscope obsolete? So we had a physician who did not have a stethoscope. Our attending at when I was, I had trained already and I was doing private practice in America. He would, come in with a stethoscope, instead of a stethoscope, a ultrasound probe on his neck, and he would, propagate that idea as well. At that time, I didn't think of it as much. I said he's just like showing off, but this is something that you have to kind of get more used to seeing on rounds. So why not consultative ultrasound? Again, consultative ultrasound is something which is more conventional. You write the order, you ask the person to go down to the radiology department, you get the technologist to do the ultrasound, then he would upload images into packs, then the radiologist, who does not know anything about the patient, would read those, make inferences, and the information gets back to you. This is something that will take a long time and also will delay the treatment. And also the person who's seeing the images, the person who's doing the images is different than the person who's seeing the images. And the person who's seeing the image doesn't know anything about the patient. They have to go back and look at whatever you have written, right information, wrong information. And again, this is something that is easy to do. And again, there are few things that you have to look for. There are plus, minus, and there are gray areas. Gray areas, you definitely need the help of an expert. But there are like plus and minus, whether it is hydronephrosis, severe hydronephrosis in the ultrasound, on ultrasound of the kidneys. This, a good eye can easily pick. So this is something that it also avoids unnecessary tests. They have actually done studies that show that if you do point of care ultrasound, you decrease the test ordering by up to 15 to 20%. And again, you can also do serial examinations. You have done the examination, like we'll talk about a little bit about fluid responsiveness. A patient crashes in the ER, hypotensive. You do an IVC assessment. You think it's collapsing. You give them fluids. The next day the person is still hypotensive, or in 6 hours the person is still hypotensive. You do another ultrasound, or the IVC is still collapsing. So you give more fluids. Okay, and now the clinical signs of volume overload will come late. Basal crackers, raised JVD, pedal edema, all of these things will come very late. You have to kind of assess, the patient is still hypotensive. You put a probe again. Now the IVC is dilated. It's not compressible. And you see other signs of hepatic congestion, renal congestion. You say that's enough. The patient is not fluid responsive anymore. He's not fluid tolerant. He's going to develop. If we continue doing this, we're actually going to harm the patient. And there are actually studies in ICU that show that overhydration or volume overload actually harms, increases mortality, morbidity. So at that point you'll say, okay, start inotropes, get some other help, get an echo, all these things. So this serial examination is also very important. And there are other things that and in foreign it's very important to do clinical documentation. Everything that you do the machine saves, and with the new machines they actually is linked to the emergency electronic medical record as well. So all of these things would help you in the long run in doing this. So we used to have these big machines, we still have these here but now we get a briefcase. This was is actually called the Sonosite. We used that when we were in our fellowship. It's like a briefcase. It has the ultrasound and the keyboard here. Then it became a probe, but this is a bigger screen using it through iPad. But now you have this is Butterfly actually from Philips, and you can actually use it on your iPhone, and it has good decent images. Again, the higher end machine will have better image quality and everything and more features, but you can do at least maybe 70-80% of the task from this portable probes as well.
A few years back, this probe, the cost of the probe was 2 lakh rupees. And how much this will cost per year? You have to take subscription per year. And
now they are making
costly, I think so 8 lakh rupees or 10 lakh rupees per
so
year.
When I was coming here in 2021, I think about 6 months ago, I said that okay, maybe I should buy this. The cost of this Butterfly was $2,000, but the subscription per month was about $150 per month, and you cannot use the software unless you have a subscription. Otherwise, if you don't have the software, the probe is useless. So, but it's getting cheaper. It's getting cheaper. The technology is there. It's already there are multiple companies. GE is making probes, portable probes. Philips is making probes. Sonosite is another company. There is Cosmos, which we used when we did our workshop. So the probes are expensive, but they have a lifespan of about 10 plus years. So once you have an initial investment into buying a couple of probes, you can use it anywhere in the hospital.
$100 is 30,000 rupees per month.
150 at that time 2 years ago. It is going to get cheaper, and again what I'm saying is that you'll see these come up and person getting trained in them. It's actually made a part of nephrology fellowship training now since 2019 or 2020. So my friend who was a moderator in this workshop is actually training his fellows. He is a transplant nephrologist, and he is working in Sheikh Shakhbout Medical Center. It's a big city. It's actually a medical city, and he's training his nephrologist fellows in point of care ultrasound. So one thing you have to understand is that it does not take away your clinical examination. You still have to take a good history. You still have to examine the patient, make inferences. This is an adjunct to physical examination. It is not a substitute for it. And there are limited numbers of things that you can see, because you cannot become a master ultrasonographer by doing this. Okay, you have to get used to making getting the images, interpreting them, and the more you do it, you'll get better at it. But it does not replace experienced sonographer in your facility. But you don't have to be an expert in doing this. Why is ultrasound so easy to use? Because it's inexpensive, cost effective, it is safe, there are no ionizing radiations in it, it doesn't make you claustrophobic, there is nothing invasive you're doing to the patient, just some cold gel. It's an easy learning curve. They've actually done studies in teaching novices about this ultrasound. They said if you do 10 serial examinations with an ultrasound probe in one area, like ultrasound of the heart or the kidneys or the liver or the IVC, minimum 10 you do with some expert, the rest you can do on your own. So there are some studies that say 25 minimum, but again it's still easy to do. 10 patients, you're on your own, Avenues everywhere. You can do it in OPD, you can do it in ICU. ICU is a big venue, or OBGYN, nephrology, fluid responsiveness, fluid tolerance. In IPD, radiological procedures, doing a drain, doing a pigtail, draining an abscess, doing a lumbar puncture, you can use an ultrasound. Putting in central lines, peripheral lines, these are things that you can use everywhere. We had a sonosite with the nurses. They used to put in PICC lines and IV lines with the help of a sonosite. Okay. This is important slide. So what can you do with the POCUS? You can determine lung pathology. They had actually validated this use in COVID pneumonia, and in ARDS there are actually specific features of COVID pneumonia that you can discern, and actually it says the sensitivity is as good as a CT scan. As good as a CT scan. The CT scan here costs how much, and how much does an ultrasound cost? Especially for third world countries who are already resource limited, as good as CT scan in ARDS. Abdominal pathology, fast exam. I'm not going to go into that. Volume status determination, VexUS score, which is venous ultrasound, venous expansion ultrasound score. Renal pathology, look at hydronephrosis. Mild you can miss, but moderate to severe you can get. You can also look at stones, you can look at the ureters, you can look at the bladder, you can do bladder ultrasound, bladder capacity, PVRs, which is post-void residuals at bedside, echocardiography. The machine that we use actually would, if you put in the images and you would load up the images in the machine automatically calculates the ejection fraction for you. You have to do two dimensional, the longitudinal and the cross sectional, and it would do the measurement on its own. You don't have to put in anything. This is artificial intelligence with this. Point of care ultrasound for evaluation of acute dyspnea and the ED. This was published in 2017. They had almost 2,600, 2,700 patients included, and they compared clinical versus ultrasound diagnosis, and they found out that the ultrasound was more sensitive in diagnosis of CHF and pleural effusions. You can do it, you can actually drain them at bedside as well. It was not as good as picking up pneumonias, pericardial effusions. You can, and again, this was actually not point of care ultrasound. These were not novices, they were experts, radiologists. So, but this gives you an idea that if you learn this technique, you can help your patients. This was comparison of point of care ultrasound and between POCUS, and again these are relatively novices that are doing POCUSes, non-cardiologists and non-radiologists, and this was actual consultative ultrasound, which is the conventional ultrasound performed by radiologists and cardiologists. Limitations are two that if you don't have adequate training on this, you can misinterpret, and there is a limitation slide at the end as well, but you can actually do a lot of benefit to the patient. Actually, it says that ACGME, which is the American Accreditation Council for CMEs and for the education, like a GME in UK, like CPSP here, they're actually looking at developing competency programs during their residency, their interns and their house jobians, medical officer level. They are trying to get adequacy and competency programs in them incorporated in their general training. So maybe 5 years down the line, Everybody will be using the ultrasound. If you go outside to study, you'll see this. Diagnostic accuracy. So this was a study, again same study from the other, the one I showed you before. The sensitivity for picking up acute pulmonary edema was 88%, specificity was 90%, close to 90%. For pneumonia, specificity was 93%. For pneumothorax, specificity was 100%. But I mean, it's more difficult to pick. But if you, so sensitivity is less, but if you see the sign, which is called a curtain sign, if you see this, that's 100% pneumothorax. Left ventricular dysfunction is about 88 to 96. Again, you have to do the calculations for EF, which artificial intelligence is going to do it for you as well. And for trauma, about sensitivity is 74%, again operator dependent, but specificity about 96%. This was a study in 2004 in anesthesiology, diagnostic accuracy of auscultation versus chest X-ray versus lung ultrasound. And you can see that with auscultation you can pick up about 61% of effusions. Chest X-ray is even worse, but with ultrasound you can pick up almost 93% effusion, even small effusions, if you know how to make windows. Consolidation 36%, X-ray was a little better, but ultrasound was even better, 97%. For interstitial syndromes like ARDS, pulmonary edema and stuff, this was 55%. And again, you know, these signs are late signs, bronchial breathing and, you know, end inspiratory crepitations, fine crepitations, but the sensitivity of the ultrasound was 95%, picking up alveolar dysfunction. What is the impact factor? 177 consecutive patients. This was a study actually done in Uganda. Again, you know, we are heading towards being Uganda at some point because of our political and, you know, unrest situation. But, you know, they did 177 consecutive patients. That diagnosis confirmed in 50% of the cases with the ultrasound, but their clinical suggestion was it was confirmed in 50% at the bedside. They didn't have to go anywhere. And there was a change in diagnosis almost 1/4 of the patients. There was a change in treatment plan in about 53% of the patients. Almost half the patients that you did ultrasound on, you had a change in treatment plan. So impact is, if you do a total almost 73, almost 3/4 of the patient that you did an ultrasound on, you had a change in their management plan. So this benefits patients. DVT surveillance. They did a study that the surveillance or no surveillance in ICU patient, in critically ill patient. This was part of a sub-study of PREVENT trial. Almost 1,700 patients were studies. They did ultrasound twice weekly for DVT screening, just 2-point ultrasound, you know, below knee, above knee. 2-point bedside ultrasound. Primary outcome, they actually was surprising that they were able to pick up more DVTs with this 4 days earlier versus 20 days. And they also but they did not find any increase in the incidence of PEs. But there was a primary outcome decrease in 90-day mortality. This was surprising. Even if the PE rates were similar, but these patients can have minor PEs that would actually impact 90-day mortality in these patients. Adjusted hazard ratio was 0.75, 0.57 to 0.98 confidence intervals. So there was you know, you have to anticoagulate more patients. So there was sometime bleeding risk as well. But the overall outcome of this was that there was a decrease in 90-day mortality. Just takes you 5 minutes to improve patient care. This is VexUS scoring. They are actually developing this, grade 1, grade 2, grade 3. This is for hepatic congestion, hepatic veins, portal veins, IVC, renal veins, for hepatic congestion, volume overload, under perfusion, over perfusion, and you can help your patients with that. I actually don't want to go into details of any of these. I just want to again impart that enthusiasm that I have and Dr. Aitasham has and other physicians have for the newer generation, newer blood, to start using this. And again, we are here to help you, guide you, and again, we are all learners in this, so we can help each other out. Grade 3 VexUS strongly associated with acute kidney injury. I forgot to mention the reference for that, but they had 706 patients assessments, and grade 3 VexUS, if you find that they actually increases acute kidney injury. Volume overload actually worsens patient's condition. Now, artificial, and this is what I was talking to you about. When we did our examination and evaluations with at Abu Dhabi, they actually, the machine itself would tell you where to put the probe in and actually show you with pictures, put the probe in, tilt it down, tilt it up. Artificial intelligence was actually helping you out. When you get the probe in the right position, it would turn green, okay, and then it would actually calculate it for you. Let's say hold, and it would calculate, this is the right atrium, this is the left atrium, this is left ventricle, this is the outflow tract, this is the LVOT, VTI, velocity time integral, calculate ejection fraction, said put the probe in here, get the longitudinal ultrasound of the left ventricle, and then turn the probe 90 degrees and get the cross section, and it will save the picture, automatically calculated within, it takes like 5 seconds, 10 seconds to give you the ejection fraction at bedside, not doing anything. So they do helpful with EF determination, in data gathering, and improves your learning curve as well. How to make images, it improves that. So in 2011, we recognized that there is a change in clinical management by doing point of care ultrasounds. In about 2015, they started using it as a hemodynamic monitoring tool in the trauma way. In 2016, in cardiac management, it started coming in. 2018, they started certification in that. We have it's a UK based point of care ultrasound academy, and it has multiple branches, and one in Seattle, America, in UK, in Abu Dhabi, they have a class there as well. And as long as you get a low cost handheld ultrasound probe that you can carry and it's portable, you can do all this. And now they are doing AI algorithms in these machines.
In 2021, point of care ultrasonography extended to the evaluation of brain also.
Brain?
Yes.
Okay.
You keep the probe here and you can visualize middle cerebral artery,
pulse waves.
cerebral artery, posterior cerebral artery. You can take breast radial Doppler, like you can see the velocities in patients of subarachnoid hemorrhage, and you can evaluate whether this patient is in vasospasm or not. So this is how focus is getting advanced.
There is also, they are doing it, using it in CPR as well.
Yes.
In looking for carotid pulses, you can just put a probe in, you'll get a carotid pulse. You can look at the EF, you can look at the whether the heart is pumping or not. There is a thing called pulse electrical activity, and there is a pseudo PEA that you can differentiate if you put a probe in. They just take 10 seconds. Okay, so they're using it in cardiopulmonary resuscitations as well. This is the word of caution I want to tell you about, is that the findings must be correctly integrated into clinical decision making process, and if you are not sure of a finding, you should not make medical decision based on that one finding. Okay, it has to come into the whole scenario, which is true with any examination. If one clinical sign is going opposite to the rest of the clinical sign, you just ignore it, or you find a better explanation for it, but do not make that judgment call on just one thing. You have to look at, if you're not certain, don't use it in clinical decision making. So is this evolution is inevitable? This actually I found it on Google. So you see, we were using sticks and stones. Our orthopods are still using these and drill machines. And then we went up to using stethoscopes, but now, you know, that's the evolution that you have to eventually go through and come across. Okay. So that was my presentation. Any questions? Thank you very much for listening, though.
In which, like in any, I don't think it's being used in Pakistan. Is there any centers in abroad where you went for the training? Are they using it on, like, as still evolving?
No, yes, that's the one. Dr. Siddiq Anwar was the one who invited me. Let me. So he's actually trained. He's actually a trained nephrologist. These are all nephrologists, by the way. She's a radiologist. He's an interventional radiologist. He is an interventional nephrologist. He's an interventional nephrologist, and he is the head. I don't know what he does, but he made the company actually. Okay, so they are all already using it in clinical. He has about 10 probes. That's what he actually showed us, and he had about 10 portable probes. They put it in the pocket. It's actually not 3 different probes, you know, the curvilinear, the linear, and the phase array, which we do cardiac ultrasound, is actually one probe. And there is another probe that you use for, you know, very low depth, maybe linear probe. But the curvilinear and the phase array probe, they have combined into one. And there is one probe you put in the pocket. You have your iPhone with you. Okay, you go on rounds, and he's actually doing this already. So you make that decision there and then at the bedside. Takes you 5 minutes extra maybe, and he's actually teaching his fellows. And again, I'm telling you, ACGME is going to integrate. He's already looking at, you know, competency programs, how to incorporate that into the regular general clinical training of their residents. Yeah, I'm not talking about, you know, consultant level. The residents are going to learn this. Okay.
But on one hand, we have trained radiologists, sonologists. On the other hand, we have clinicians who think they have a very high steep learning curve, and by doing 10 examinations, they can perform it. Has there been any study which compares the results of both of whether the clinicians who did that at bedside and whether those results compared with the clinicians or radiologists who did on a proper ultrasound in the department? And was there any? Because there were so many factors. There was a cost effectiveness.
Yes.
There was a clinical examination.
This was being studied. So this was actually, they did point comparison between non-radiologists and non-cardiologists doing POCUS. This is not from Uganda. This is NEJM. I think this was 2016 or something, right? And then doing regular ultrasound. I didn't explain that as much, but you know, again, the disclaimer is, we are not taking away the job of the sonographers. We are not taking away this. Okay, we are actually improving clinical care of patients by doing rapid assessments, augmenting our clinical examination through that, and then making point of care decisions on what to do next. And you cannot ask the sonographer to come in, you know, after 4 hours, assess the IVC again, give me fluid responsiveness, give me ejection fraction, okay, or you know, do whatever, you know, that like they did DVT screening twice a week. You cannot ask your radiologist to come in every time and, you know, come in the middle of the night or doing this. And again, there are gray areas that need expert opinion. There are negative findings that you can easily rule out, and there are definitely positive findings. Like if you say you have hydronephrosis, there is no hydronephrosis, you can easily say, if you train your eyes enough, and there is severe hydronephrosis, moderate to severe. In the middle, you know, mild or, you know, dilated calyces, mild hydronephrosis, maybe mild to moderate, you may not be able to discern. I understand that there is an operator, you know, learning curve as well. But there are, you know, the extremes you can easily pick up. And again, it's at the point of care ultrasound that you're doing it at bedside. It actually improves trust in the patients trust you more because you're doing something to them. And we are not charging it as yet. We are not charging any of this. You're just using some gel and maybe a little bit of electricity.
No, it's not matter of cost effectiveness will come. I'm just talking about, because in this study, they said that how many days you require, some requirement, for example, you say 300 TT and 50 TEs, and then same for the ultrasound. But my point is that was there any comparison in terms of results, whether false positive, false negative, which led to any kind of clinical implications or any adverse event or any misdiagnosis?
ये हैं सर स्टडीज हैं जो सर पूछ रहे हैं ना बेसिकली कि वो पूछना चाह रहे हैं कि हाउ फोकस इज मेकिंग अ डिफरेंस, हाउ फोकस इज मेकिंग अ क्लिनिकल डिफरेंस. इस पे ऊपर हैं सर स्टडीज हैं काफ़ी सारी हैं और ये 2015 के बाद की स्टडीज हैं. आई कैन शेयर, बिल्कुल है सर. अभी तो सर हम ये कर रहे हैं कि हम लोग ना आर्टिफिशियल जो मशीन्स हैं, जैसे आपने बात की, ये जो सॉफ्टवेयर है ना, इसके अंदर उन्होंने एआई को इंटीग्रेट कर रहे हैं. आप प्रोब रखें, एआई विल टेल यू एवरीथिंग. ये VexUS भी आपको एआई बताएगा. फिर हम इनको एल्गोरिदम्स में इनकॉर्पोरेट कर रहे हैं, जैसे हाइपोनेट्रीमिया की इवैल्यूएशन में भी इनकॉर्पोरेट कर रहे हैं, एक्यूट हाइपोक्सीमिक रेस्पिरेटरी फेलियर के अंदर हम कर रहे हैं. तो इस तरह हर उसके अंदर कर रहे हैं. तो आपका जो एल्गोरिदम के बाद एआई के साथ जो आपके एल्गोरिदम है ना, यू विल बी इन अ बेटर पोजीशन टू डायग्नोज योर पेशेंट्स. तो वो इट्स गोइंग टू मेक अ डिफरेंस.
The more common the thing is, the more studies it will come, and again it will actually there are studies that show that there is change in different mortality, and I showed you just by doing DVT screening you can actually improve mortality of your patients.
Focus की images वो print भी हो जाते हैं, सेव हो जाते हैं,
तो सेव भी हो जाएंगे सर स्टडी.
सर ये आईफोन के अंदर, आईपैड के अंदर आप सेव करें, और ये मैंने बताया ना क्लिनिकल डॉक्यूमेंटेशन में भी ये हेल्प करेगा आपकी. आपने किया, आपने कहा जी ये मैंने प्रोब रखा.
It's a future, I can tell you from now onward. But I'm just talking about initially in terms of training of the clinician, because clinician on one aspect has a better access of the patient because he has clinically, physically examined the patient history, and he has got more clinical acumen as compared to the radiologist. But they have the more edge on the investigation itself, but the clinician has more edge on the total picture of the patient. So I'm more interested in what outcomes are the better for which cohort of the clinician, whether radiologist or whether it may even come out better for the physicians.
Yes,
they
yes.
have more clinical insight into the thing.
इसके ऊपर सर स्टडीज हैं कि जो आपने पॉइंट ऑफ केयर स्कैन जो है which is done by the clinicians that makes a difference by as compared to the scan done by the radiologist. जैसे वो कंसल्टेटिव आपने बात की, उसमें इसमें है स्टडीज.
सर उसमें एक सबसे बड़ी बात है ना कॉस्ट की, दूसरा है टाइम है आपका. अब ये देखें ना, अब आपका डिले इन परफॉर्मेंस है, डिले इन परफॉर्मेंस इंटरप्रिटेशन एंड कम्युनिकेशन ऑफ रिजल्ट्स टू फिजिशियन डायरेक्टली रिस्पॉन्सिबल फॉर मैनेजमेंट, कंपाउंडेड बाय कंसल्टेंट्स लैक ऑफ फुल नॉलेज ऑफ क्लिनिकल सिचुएशन एंड इंक्रीज हेल्थ केयर कॉस्ट्स.
Again, time limitation, it can be done any 24/7 any time. But obviously this may become integrated as part of the trainings.
And again, for nephrology trainees, it's already started because we deal with fluid a lot. So, and again, I was not trained into it. So, this is something that's going to come up again and again and again. Okay.
Thank you, sir. Thank you.
Thank you very much. Thank you for coming.